interesting thing is, as was mentioned earlier also, that the treatment paradigm of a hormone positive, HER2 negative advanced breast cancer has changed. We have Dr. Deepak Dabkara sir with us, and I'd request sir to actually throw in some light that during his treatment course, how has this therapeutic option evolved, and what changes had it shown, and how easy or difficult was it to involve in practice a CDK4/6 inhibitor at that time? So
the treatment which was there was letrozole initially and fulvestrant. This was before the CDK4/6 inhibitors came into picture, and after that palbociclib was the first molecule. After that ribociclib and abemaciclib came, and means as per the results of these various trials, we see that there is a significant advantage in PFS, at least doubling of PFS in most of the trials. And the ribociclib also shows overall survival advantage both in premenopausal, postmenopausal patients. And toxicity wise, the toxicity are very less, well tolerated, and rarely we see that a patient has to stop ribociclib or palbociclib because of severe toxicity. So things have changed, and in second line also after letrozole or CDK4 with letrozole, we also have second line treatment abemaciclib. I have not used in much patients, but things have changed in last 5 to 10 years.
Dr. Vikas Sasati sir is here with us, and to admit honestly, he's seeing a very wide variety of patients in his practice, from patients with a poor background in SAMES to people who are fairly affordable at Chohetram. So sir, how easy is the acceptance of these drugs in practice currently? As in, what proportion of the patients take it upfront or subsequently in your practice?
So thank you, Dr. Akash, for giving this opportunity. So answer your question that yes, I have a patients like who are like, to start with, they start on letrozole, and to be very frank, hardly 10 to 20% of my patients can afford either of the CDK4/6 inhibitor. So 70 to 80% patients are still on either on AI or tamoxifen, and you know that the PFS is definitely better when you add CDK4/6 inhibitor. But even single agent letrozole, or if patient is premenopausal, then ovarian suppression plus letrozole, I think those are also a very good options. But yes, we know that the mechanism of resistance will develop very soon as compared to the patient when someone is taking CDK4/6 inhibitor. So yes, we have OS data also in the first line, second line setting, that they are not only increasing the PFS, they are also going to increase the survival of the patients. But you know, I think the best, most important toxicity that we all are facing, including our patient, is the financial toxicity. Both the drugs, either letrozole or any other AI, plus any of the CDK4/6 inhibitor except Abiva, which has diarrhea. I have never used that drug. Either you take Pelvo or Ribo, both are like wonderful drugs, effective drugs, and the toxicity is the paper toxicity. You will have neutropenia on your report. So I think that's all from my side.
So we know that the therapeutic options, as was mentioned, has evolved rapidly in hormone positive, HER2 negative breast cancer, from being only fulvestrant and AIs and tamoxifen for a large period of time. Yes. And to a large extent, as Dr. Asati sir was mentioning, still because of the cost issues, to an addition of CDK4/6 inhibitor, which has given a substantial improvement in the PFS, improved quality of life, and certain drugs, even overall survival. So currently, CDK4/6 inhibitors and its combination with ET are driving better patient outcomes, undoubtedly, with better PFSs and better outcomes for both premenopausal as well as postmenopausal women. So premenopausal women, we know that by NCCN, the standard of care remains an ovarian ablation plus ET plus minus a CDK4/6 inhibitor, most pluses than minuses, or a selective ER modulator, a fulvestrant is another option. For postmenopausal women, an AI plus CDK4/6 inhibitor or a fulvestrant plus CDK4/6 inhibitors for women who are not in visceral crisis are the standard of care. So I like to start with Dr. Suneet Lokwani, sir, and with a question that we often face in our practice is that what are the treatment goals that we must look at when we are offering these drugs to the patient, and so that it is easier for us to make them understand also why is it beneficial to us to them. Suneet, sir.
Thank you, Akash, for calling me to this panel discussion, and I'm really humbled and obliged by the organizers. And thank you, Akash. And I welcome all my friends, Deepak sir, everybody. Just to begin my answer, before that, I would like to state what Vikas told already. When he was telling that financial toxicity is one of the major toxicities we face while prescribing CDK4/6. So, I mean, when we studied CDK4/6 10 years back, we never thought that it will be such a streamlined thing. I mean, I personally didn't think that way. And now when it is in club and combination with one of the drugs which we give for years together, so things have evolved definitely. And when we are not able to give CDK4/6 to our patients, it definitely hurts us that we're not giving proper, complete care. And because we know from the inside, the idea is to prolong the area of OS per se. And when Vikas was telling this, मुझे राहत इंदौरी साहब की 2 लाइनें याद आई कि जरूरी नहीं कि सब कुछ मुकम्मल हो प्यार में, कुछ किस्से अधूरे ही अच्छे.
सही है. कॉलेज की याद आ गई इस बात से.
तो तुम्हारा तो किस्सा मुकम्मल हुआ भाई, तुम्हारे तो बैठता ही नहीं बोल रहा तुम.
नहीं फिर से एक बार बोलो. फिर
राहत इंदौरी साहब की 2 लाइनें थी कि जरूरी नहीं कि सब कुछ मुकम्मल हो प्यार में,
वही सब कुछ
किस्से कुछ किस्से अधूरे ही अच्छे. So please pardon me, Deepak sir, if I'm going off track. And coming back to what Akash asked to me per se, I think so. If you consider the treatment goal part here, expanding the OS horizon would be the primary area where I would be focusing in both the subsets, and that would definitely guide me. Now, see, premenopausal young females, they are definitely one of the high risk strata or high risk category. So special attention is needed as part of the ovarian suppression and ablation is carried out there in that segment. But certainly the OS part expanding and the treatment goal from the context of the disease per se remains the same. That is what I would like to stick in.
Great. So, I was pointing out that the treatment goal predominantly would be a better response, a longer outcome in both premenopausal as well as postmenopausal women. There are certain typical challenges.
आकाश, ऐसा है कि सर आप मीठा खाने जा रहे हैं तो मीठे में क्या खाएंगे सर? हम पान खाएंगे, तो पान के साथ हमारे को क्या गुलकंद भी चाहिए, पान के साथ हमें टूटी फ्रूटी भी चाहिए. So deeper response, longer response, improved QL. These are a clubbed part of the whole spectrum. Actually.
Whole spectrum, definitely. So there's this interesting thought that we had in our minds is that when a lady, say a 60-year-old, 56, 70-year-old lady with metastatic CA breast, the decisions are easier to put them on endocrine therapy and otherwise. So I'd like to put this to Rajesh sir, and there are 2 questions in this part. One key, when these patients with young CA breasts that come to us, women with 37-year-old, 30-year-old, 35 years old, who have metastatic disease, some of them may have visceral diseases also, and they're hormone positive. Some of them strongly hormone positive. Some of them are weak hormone positive, say 6/8, the 5/8s, or 6/7/8. How do you decide then, sir, to either start them on hormonal therapy, what agent to use, and well, how do you go about the treatment here? So, Rajesh sir.
Akash, first of all, premenopause, am I audible?
Yes sir, you are.
So first of all, these premenopausal ladies, usually they have high grade tumor, chance of ER/PR positivity is less compared to the elderly ladies. And in all those ladies who are ER/PR positive, I prefer to go with the CDK4/6 inhibitor along with letrozole with ovarian suppression if at all if patient is affordable. And if patient is not affordable, then again ovarian suppression with letrozole. I prefer this regimen compared to tamoxifen. And these patients have more of psychological problems and they usually, since I have said that the disease biology is not that good as postmenopausal lady, so again there will be quality of life is poorer compared to the postmenopausal ladies and premenopausal ladies.
Great. I like to present this question probably to Dr. Vikas. So, sir, we had this patient, oligometastatic, CA breast, a 38-year-old female, 6/8 progesterone, 2 meds only. Is it better to treat them with, say, a ribociclib, ovarian suppression plus letrozole, or to treat them with a curative intent? So, how do you go about it, sir?
So basically, I would like to know where are the oligometastases are. They are in the bone,
humerus, and one in D10 vertebra.
So both are bony metastases.
Yeah.
So I think in all such cases, what I do, I start with neoadjuvant therapy, and then I repeat I do the response assessment, and if they are responding, I can treat. I have treated few of the oligometastatic diseases, may not be with ER/PR positive, but especially in HER2 positive diseases, where I have tried neoadjuvant chemotherapy, complete full 8 cycles of chemotherapy, if possible dose dense, and if possible, like we can go ahead with curative intent. I have around 6 to 7 patients where I have tried, and especially in the ER/PR positive, if we can plan the radiation at the bony lesions, oligometastatic, like I would love to do that. So provided the primary should also respond in a manner that radical surgery is possible.
So is Anup around? Dr. Anup?
And one thing more I would like to add what Dr. Rajesh told, that in premenopausal females, you are doing ovarian suppression abruptly. Either you do surgery or you do LH-RH agonist, or in whatever you use, we are doing abrupt cutoff of estrogen secretion from the ovary. I think that also caused a lot of suppression, a lot of side effect as compared to the side effect caused by either CDK4/6 or letrozole. So that is also very important. The hot flushes and all the physical and psychological side effect, it's really difficult for at least for initial 2 to 3 months.
So this is question of why is overall survival, and I'll give my take on this question subsequently. Is Anup around?
Yes, sir, I'm there.
Hi, Anup. So why do you think that overall survival is considered an important treatment goal in advanced breast cancer? And I bring this question to you specifically because before this data from Mona Lisa's in survival paradigm, there's a lot of debate that should we use CDK4/6 inhibitors at frontline, or should we use it subsequently post-progression on endocrine therapy? So we always knew that these drugs are effective. What changed in your practice with the availability of the survival data of these drugs?
Hello, good evening, sir. First of all, thank you, Novartis, for giving me this opportunity. So, as we have seen, this the progression-free survival was not the definitive criteria for overall survival. So, in metastatic setting, we are definitely looking for an overall survival. It is a more important marker as compared to progression-free survival. So, for me, in a metastatic setting, I definitely look for overall survival, and as we have seen in all the Mona Lisa trials, there is a clear overall survival seen with the use of ribociclib. So for me, overall survival is a very important bit.
Sure. So interestingly, Anup, when this data of palbociclib had come, our focus, I remember in a lot of conferences, people would say on the palbos data is that you could use it in second line. Why use it in first line? Because they have the similar overall survivals. And I think with the availability of the survival data here, probably it became easier for us to use the drugs in the first line, where I think they solve the best purposes of both improving the overall survival as well as Sir Sunit sir was mentioning, the gulkans and the tutti fruitis that also improve the quality of life. And I think with the addition of these drugs, it is we can improve both the OS as well as the quality of life. So we have this data from MONALISA 7, a phase 3 trial in the pre and the perimenopausal women. It reported the longest ever median OS in this subgroup of 58.7 months, as well as the health HR related quality of life was maintained for a longer period of time as compared to placebo. The median survival was 58.7 months in the intervention arm as compared to 48 months with a hazards ratio of 0.76. That will be around 24% relative risk reduction of mortality. In terms of the quality of life also, the time to deterioration was prolonged in ribociclib as compared to the placebo. To spin this question to Dr. Dipkara sir. So sir, with 3 drugs available as CDK4/6 inhibitor, what helps you make choice of one over the other in your practice?
So I have not used abemaciclib, but these 3 trials, ribociclib, palbociclib, abemaciclib, they all have shown that there was a significant difference in PFS with all the 3 drugs. And toxicity wise, palbociclib, ribociclib, they are nearly same. There's not much difference. So the only important factor presently is this overall survival data, which shows that in patients with bone only mets, it is about 72 months. With others also, it is nearly 60 months. So I think if you have to choose between palbociclib and ribociclib, this data is important. So I think this is the only thing at present which will make me to choose ribociclib over palbociclib. And abemaciclib data, I am not sure if it has shown a OS advantage or not. But among palbo and ribo, choice will be ribo based on this OS data. Quality of life in both these drugs, palbo and ribo, they are same. They are good.
So, Vikas sir, I came across an interesting set of data. In fact, anecdote, some of my friends from Delhi were quoting. So I asked them in respect, we were discussing in respect of a lady with liver mets, and we were planning to start her on ribociclib plus letrozole. And they told that in their practice, if patients are not affording, they usually start with a dose of 400 mg with ribociclib. And we'll come to this data subsequently, that probably dose reduction does not reduce the outcomes that significantly. So sir, have you ever used this strategy, or do you find it interesting, Vikas sir?
So reduction in the dose, like I have done in few patients, may not be with ribociclib. So I have done for serotinib. So I think Novartis people will not be unhappy. It also belongs to Novartis only. I have done with serotinib. Few of my patients taking only 1 tablet. Fewer patients are taking 2 tablets. I have only 1 patient who is taking 3 tablets. So the target therapy will definitely work even in lower dose also, because the mechanism is entirely different. The same is also true for the PARP inhibitor, rucaparib or olaparib. All patients cannot afford the full dose, so like they are benefiting. So
yes sir.
Yes, even for rucaparib, like till date, my patients are taking full dose. But if someone cannot afford, I can use it lower dose also, because we have a robust data that even by reducing the dose, it is not hampering the PFS and also the OS in a significant manner.
So sir, for a long period of time, I thought this 200 mg tablets of ribociclib are helpful, because if someone develops a toxicity, we can reduce the dose. But we never had a reason to reduce the dose because of a toxicity. They were very
correct. So that is the reason that
now I realize that the benefit of having a 200 mg tablet is that you can give a cheaper CDK4/6 inhibitor to your patients.
I think the Sunit sir want to say something.
Sunit sir.
This whole practice in Delhi, started when ruxolitinib was launched for myelofibrosis. And it being a costly molecule, people used to give 5 mg instead of giving the 15 mg despite normal platelet counts and all. And subsequently, this practice has been extrapolated to other drugs as well. And if you can see, enzalutamide also comes to 40 mg with the dose of 160. So many other drugs do follow this pattern.
So like I remember none of my like in a whole department we have 4 or 5 patients of myelofibrosis. None of the patient is taking more than 5 milligram.
Yes, that happens. That was very well started off.
No, but in that case, it is less effective. We cannot compare that example because the in that case it is less effective.
Definitely.
But what?
Agree. Totally agree. It is less effective. But
if sometimes there is a cost constraint, we will use it.
At the end of the day, that something is better than nothing part wins in most of the decision making parts.
Okay.
That way, people definitely
for
go
targeted therapies.
Yes, especially for targeted therapies.
So ribociclib we know is a potent selective CDK4/6 inhibitor. It is more potent than its competitors Abema and Palbo. Its free drug concentration is also almost 22 times higher. We know that from the subgroup analysis of the data that dose reduction does not compromise the OS benefit of the ribociclib, both in the MONALEESA 3 as well as the MONALEESA 7 trial. Of course, these dose reductions were because of toxicity and not for what we were discussing here. Ribociclib,
sorry for intervening, we have 5 minutes left to conclude.
Ribociclib is the only CDK4/6 inhibitor that has overall survival data in all 3 frontline indications, as well as in second line postmenopausal, where it has an overall survival benefit, with Abema probably having a OS benefit in one. Ribociclib is also the only CDK4/6 inhibitor to receive an ESMO MCBS score of 5, which suggests that it is of a proven clinical benefit also to the patient, apart from the statistical significance that it has. So this thought to Dr. Anup. Anup, do you think that, so we know the data, does your practice also is determined by the fact that which inhibitor, CDK4/6 inhibitor, inhibits the, improves the OS and which not?
Sir, I think we have data with ribociclib, the only CDK4 inhibitor which has shown improved overall survival in all stratas, and also the side effects in the is much more tolerable as compared to other CDK4 inhibitors. I feel ribociclib is much more tolerable. It has less myelosuppression as compared to the palbociclib, and abemaciclib I have no experience, but definitely, you know, before ribociclib, during my first years in 2017, I used to use palbociclib a lot. But in last 3-4 years, I think more and more doctors and even I have not used palbociclib for a long time, because I feel the dose reduction and toxicity wise going from 600 to 400 milligram is much more comfortable with ribociclib as compared to palbociclib.
So how do you in your practice monitor these patients subsequently? What test you get and what frequency?
So for ribociclib, I do ECG for first 2 months. And I think that later on, if there is no QT prolongation, I don't monitor ECG again. And CBC, I do it every month.
Sure. So
CBC and LFT.
So ribociclib, we know, has the longest reported safety data of any CDK4/6 inhibitors. Its predominantly toxicity is QT prolongation, but it is usually in doses more than or equal to 600 mg that we see. It has demonstrated safety across the 3 MONALEESA trials. So like other CDK4/6 inhibitor, is a safe and easily usable drug. So Deepak sir had initially answered this question of how has the paradigm changed. I like to ask him, how has the treatment paradigm changed, particularly with the updated results of the MONALEESA trial? So
just now I have answered that with these 3 palbociclib, ribociclib,
and the survival data as you were mentioning.
Yeah, the survival data, that is the most important factor at present.
I do agree, sir, that it was actually probably it became easier for us to convince patients rather than other. I know that the survival data is also determined by what populations were there. So cross-trial comparison, I'm not sure if you could do or not, but probably it became easier to convince people. So ribociclib also prolongs the time to chemotherapy as well as time to deterioration in the quality of life in patients, and hence addition of a CDK4/6 inhibitors improves both the PFS, quality of life, and some cases overall survival. Hence, whenever it is possible, I think we must add these drugs to the treatment paradigm. Thank you.